Hello, my dear friends. Welcome to our YouTube video, Nursing Mentor, A Definite Path to Success. Today, I am discussing few questions from the endocrine system. Let's go to the first question. A patient after transsphenoidal hypophyseectomy is found to have a urine output of 250 mL and 225 mL for the last 2 consecutive hours. The specific gravity of the urine was found to be 1.002. He is most likely to have. Let's go back to the question and look at few key points. The patient had transsphenoidal hypophyseectomy. So what is transsphenoidal hypophyseectomy? It is a removal of the pituitary gland. So if you look at this diagram, you can see the pituitary gland and the hypothalamus above the pituitary gland, and all the hormones produced by the hypothalamus is stored in the pituitary gland. The pituitary gland has got two lobes, the anterior lobe and the posterior lobe. And the posterior lobe stores two hormones called the oxytocin and the antidiuretic hormone. Now let's go back to the question again. The urine output was 250 mL and 225 mL for the last 2 consecutive hours. That's the second key point. And the third point is the specific gravity of the urine, which is 1.002. So these are the 3 key points from this question. Now let's go to the options. First option is SADH. Second, polyuria. Next is the diabetes insipidus. And the fourth option is low body temperature. SIADH is caused by the hypersecretion of the ADH hormone. So once the pituitary is removed, if there is a hypersecretion of ADH in the blood, it can cause SIDH. Polyuria. Patients can have polyuria after surgery, and it can be of any reasons. So that is increased secretion of urine. The next option is diabetes insipidus. That is caused by the hyposecretion of ADH. And there are certain criterias for diabetes insipidus. Let's have a look at the criterias. The criteria for diabetes insipidus include urine output greater than 200 mL for the first 2 consecutive hours. It need not to be the first 2 hours. The urine specific gravity between 1.001 to 1.005, and a serum osmolality greater than 295 milliosmoles per kilo. These are the criteria for diabetes insipidus. So if we come back to this question again, we can understand that from the criteria that we have seen just before, we can see that the patient's urine output was greater than 200 mL for 2 consecutive hours, and also the specific gravity of urine is 1.002, which is within the criteria for diabetes insipidus. So the best option among the 4 is diabetes insipidus. Let's go to the next question. A patient with type 2 diabetes mellitus is receiving 26 units of NPH insulin daily at 7:30 a.m. Teaching for the patient should include: the NPH insulin is an intermediate acting insulin. Let's go through the insulin types and see how the action times are. The first one is rapid acting insulin, and it starts working within the 15 minutes of administration, and the peak action is after an hour of administration. And this insulin is effective for the first 2 to 4 hours. And the examples include Lispro, Humalog, Aspart, Novolog, etc. Next is the regular or short acting insulin, which starts working in 30 minutes, and the action time peaks between 2 to 3 hours. And the duration is that the insulin is effective for 3 to 6 hours. And the examples include Humulin R, Novolin R. The third one is intermediate acting insulin, which starts working within the 2nd and 4th hour. The peak action occurs from the 4th hour to 12 hours, and it's effective for 12 to 18 hours. And the examples are NPH Humulin N insulin or NPH Novolin N insulin. Long-acting insulin, it starts working after several hours and it's effective for 24 hours or more. And the examples are as follows. The ultra long acting, which also similar to the long acting, starts working after several hours and it's effective for more than 42 hours. And the examples are Digludec or Tresiba. Let's come back to the question. The patient is receiving NPH insulin daily, and NPH, and we know from the chart before that NPH insulin belongs to the intermediate acting insulin. And because he is taking the insulin at 7:30 a.m., the action of NPH insulin peaks at the 8th hour. So there is a chance for hypoglycemia around 4 o'clock or 4:30 p.m. Now let's go into the options. The first option is exercise for 30 minutes prior to lunch. And option number 2 is exercise for 30 minutes before bedtime. These two options will increase the chance for hypoglycemia. So we shouldn't be teaching the patient to exercise before lunch or before bedtime. Third option is consume a snack at 4:30 p.m. And we've seen that the hypoglycemia risk will be around the 8th hour for this particular insulin because the patient takes insulin at 7:30 a.m. So consuming a snack at 4:30 p.m. would be ideal for that patient. So the best option or the answer for this question is consume a snack at 4:30 p.m. Let's have a look at the next question. A patient with rheumatoid arthritis is receiving methylprednisolone 5 mg for the last 4 months. Sudden stoppage of the drug may cause hyponatremia, B. hyponatremia, hypoglycemia, hypokalemia. Let's have a look at what happens when a patient takes any steroids. So in the body, the steroid level is controlled by the hypothalamus, pituitary, and adrenal glands. And it's called HPA axis that controls the steroids levels in the body. But when a patient takes methylprednisolone, the body gets tuned in such a way that the steroid production in the body itself slows down because there's an external source of steroid, and the body will be used to that for such a long time. When we suddenly stop the external steroid, which is the methylprednisolone, the body will go into a crisis which is called adrenal insufficiency. And in adrenal insufficiency, what happens is that there will be reduced production of mineralocorticoids, there will be reduced production of glucocorticoids, and there will be reduced production of sex corticoids. Now let's come back to this question. So a decreased production of glucocorticoids results in hypoglycemia, and a decreased production of the mineralocorticoids results in hyponatremia and hypokalemia. So the best option among the 4 is hyponatremia. Let's have a look at another question. Myxedema coma is characterized by all except hypertension, hypothermia, bradycardia, hyponatremia. What is myxedema coma? Myxedema coma is a severe form of hypothyroidism. This can be precipitated by a physical stress such as surgery or a sudden medical illness or a personal stress or sudden stoppage of medications used to treat hypothyroidism such as levothyroxine. Myxedema coma is characterized by hypotension, hypothermia, bradycardia, hyponatremia, and hypoglycemia. So the correct answer here is hypertension because hypotension is a feature of myxedema coma. For more questions like this, please subscribe to our YouTube channel Nursing Mentor, a definite path to success, and also please wait for our app to be released. Thank you.